Hello everyone, Donna Levin here with the Network for Public Health Law. Before we begin our closing plenary, I just want to take a few minutes to thank all of you for attending the summit and all of our speakers for the valuable insights and information they've presented. In this difficult time, your work is of paramount importance, and I encourage you to continue to connect with one another, to share your knowledge, expertise, and ideas. And as always, the network is available to you to provide assistance or connect you with our partners. We have a great closing plenary, and it is my pleasure to introduce John Monahan, who will be the moderator for this plenary. John is Senior Advisor for Global Initiatives to the President of Georgetown University and a Network for Public Health Law Advisory Board member. Thank you, John.
Donna, thank you so much, and it's really it's an honor and a privilege to serve on the National Advisory Board for the network. And congratulations to you and your team for organizing such a timely and important conference. It's difficult to imagine a moment where we need the kind of reflection that this conference is providing. I mean, this pandemic has certainly caused all of us to think hard and differently about public health law. So thank you for everything you're doing. As said, I'm really thrilled to be the moderator of this closing plenary that's entitled From Global to Local, Guiding COVID-19 Laws and Policies. And I'll tell you, we have a stellar group of panelists that I'll introduce in a moment. And we're planning to have, after their presentations, an informal discussion and then opening it up to all of you in the audience. But I also thought maybe as we think about this sort of broad topic, I thought I might share a couple thoughts in advance, since so many of you out there are public health lawyers and practitioners in the United States. So obviously as a threshold matter, we all know that there's international law that governs pandemics, not including the international health regulations and several other laws. We also know there's obviously law at the national and local level that applies to COVID-19. But I also, beyond that sort of black letter law, I guess I'd ask you to maybe think of today's presentation with sort of two lenses on. One is sort of a vertical lens, to think, how well do laws at the global, the national, subnational, local level harmonize among each other? One thing we know about this virus is that it affects different people at different places, at different times, and in different ways. How well does that suite of legal laws and regulations work in different places? And then, particularly as U.S. lawyers, and I can say this as somebody who, I spent the bulk of my career working on domestic work before working in the global space. Can we, as awful as this moment is, there is a chance here, I think, for us to look horizontally. How can we look at how other people and other lawyers in different systems, albeit with different cultures and contexts, how have we approached a common virus with the tools of law, for better or worse? And I think if we can think of this as a way to imagine a global learning exchange, that might be a positive way to think through this. Certainly think through the panel today, but also think through what we can get out of this experience. So at any rate, I just thought offer that idea of a sort of vertical and horizontal lens to the really stellar people that we have on the panel today. So let me, because we're relatively short on time and you have all this material, let me just quickly tell you who our speakers are. The first is Lindsay Wiley, who's a professor of law and the director of the Health, Law, and Policy program at American University. She has written extensively on public health law. She is the co-author of the Public Health Law, Power, Duty, Restraint, and also the Public Health Law Reader. She with Larry Gostin at Georgetown, and she is the former head of the Global Health LLM program at Georgetown. So Lindsay will start us off, and then we'll turn to Matt Kavanaugh, who is a professor of law at Georgetown, and he's the director of the Global Health Policy and Politics Initiative at the O'Neill Institute. He's also an assistant professor at our School of Nursing and Health Studies at Georgetown. And then finally, we will have the honor of Umunyana Rugege, who is the executive director of Section 27, a human rights organization based in South Africa. And she is a human rights lawyer by training. She's been with Section 27 since its founding in 2010. She holds a bachelor's in environmental studies from the State University of New York at Buffalo, and an LLB from the University of Cape Town. She has appeared in many publications and in the media talking about the critical issues of health and human rights. So needless to say, we have a stellar group with us. So just quickly, the format will be, I'm going to ask each of our panelists to spend 3 or 4 minutes talking a bit about their work, and then we'll open it up for a longer conversation. So let me start by turning this over to Lindsay, who will kick us off, and we'll go from there. So thank you, Lindsay. We really appreciate it.
Thank you, John. It's an honor to be joining this illustrious group. And I'm really happy to be addressing the summit audience this afternoon for the closing plenary. My focus over the last several months has been predominantly on the state and local response to COVID within the US. But as a public health law scholar who began my career working for John as a global health law scholar, I always approach legal developments within the US from a global perspective. An overarching theme that we want to focus on in this closing plenary discussion, among others, is the balance between restrictions and supports. And that's going to be the main focus of my initial remarks. Slide, please. I find the global human rights framework immensely helpful in thinking about governmental obligations. Although social, economic, and cultural rights aren't justiciable in the US to the same degree that they are in many other parts of the world, this basic framework is still a very helpful way of engaging a public health problem-solving process rooted in justice. Like other public health problem-solving tools, this framework helps us avoid being ruled by our intuitions in pandemic response. It helps us see opportunities for intervention that we might otherwise miss, especially at a time when so many elected officials in the US, globally, and elsewhere are deflecting blame from their own failures by encouraging us to turn on each other, to police our neighbors' behavior, and to blame them, when in reality we're all in this situation together, and government is supposed to be how we achieve collectively what we can't achieve individually. General Comment 14 on the right to health describes 3 basic types of governmental obligations: obligations to respect health-related rights, obligations to protect health-related rights, and obligations to fulfill those rights. The applicable legal standards may vary from country to country, but as a general principle, obligations to respect health-related rights require that government restrictions on individual rights must be necessary, meaning they must be consistent with the best available scientific understanding. Restrictions must be proportionate to the threat and time limited as appropriate, and they must be non-discriminatory. Obligations to protect health-related rights require governments to regulate non-state actors, who might include employers, landlords, businesses operating high-risk facilities, and others, to ensure that they don't interfere with the public's health inappropriately. And finally, obligations to fulfill health-related rights require governments to proactively engage in activities and provide financial and other supports to strengthen realization of the highest attainable mental and physical health. Slide, please. In a pandemic, this framework maps nicely onto the various powers and responsibilities of government that we're seeing in action to varying degrees across the globe. To an extent that's varied from place to place and from time to time, governments are taking action to ensure access to healthcare, including the development and distribution of safe and effective diagnostics, therapeutics, and vaccines, and to increase healthcare capacity to provide screening, treatment, and eventually vaccination. Efforts to conduct ongoing risk assessments, disease surveillance, and evaluation of public health interventions are critical. And it's equally critical for government to communicate with the public and particular stakeholders about the findings of these ongoing assessments to ensure a transparent response. One of the most controversial aspects of the government response is in the realm of community mitigation. Governments have altered the operation of public facilities and services, especially schools. They've regulated businesses, ordering them to close to the public, cease on-site operations, or follow density restrictions and sanitation requirements. And they've regulated personal movement and behavior through travel restrictions, stay-at-home orders, gathering bans, mask requirements, and more. But I want to focus on an area that's been particularly neglected across the globe, which is the power and duty of governments to provide social supports to enable compliance with public health guidance and minimize secondary harms. Slide, please. One of the key themes of this conference has been the breathtaking disparities in COVID infection, morbidity, and mortality that we've seen across the US, with Black, Indigenous, and Latinx people experiencing sharply disproportionate impacts, both in terms of the primary impacts of infection and in terms of secondary harms caused by healthcare, economic, educational, and social disruption. As we'll discuss in this session, similar patterns are seen again and again from region to region and country to country. These disparities are the result of structural racism and other forms of social subordination affecting intersecting populations of Black and Indigenous people and other people, low-wage and disempowered workers, people with disabilities, people in custody, people experiencing homelessness and domestic violence, people living in communal, low-income and rental housing, and other socially subordinated groups. Governments have obligations to provide social supports, legal protections, and accommodations to enable compliance with public health recommendations and minimize secondary harms. They have the power and the duty to provide legal protections to preserve employment, income, housing, and utilities, to ensure safe and sanitary and accessible housing conditions for all, and provide financial support and direct delivery of essential goods and services. Restrictions without accompanying supports exacerbate injustice. Restrictions without supports result in deeply unjust distributions of the benefits and burdens of our public health response to this pandemic. Slide, please. As I wrap up, I just want to highlight a fantastic article published yesterday in BMJ Global Health that discusses these themes in more detail. I highly recommend that you check it out. I think it's got a lot that those of us engaged in the domestic US response to COVID-19 can benefit from and learn from. With that, I'll turn it over to Matt Kavanaugh, who's been tracking cross-national trends in each of the realms that I've mentioned here. Thank you.
Thanks so much, Lindsay, and thanks to the network for having me on and having all of us on. I hear that it's been a fantastic day of activities and that you've produced something kind of amazing, and so I'm very excited to see some of it. I'm someone who works on the global side of things mostly, and so the engagement of domestic colleagues, domestic lawyers, domestic public health people in thinking about the messages from the global sphere is my happy place. So thanks you all for joining this last session. So look, the thing that you all know really clearly is that under COVID, law matters massively, right? In the absence of a vaccine, effective treatment, cure, in that way, this pandemic is really, mirrors others, including HIV, which I've spent most of my career working on in one form or another. But it's also a really interesting, unique moment because this pandemic is happening across the world, affecting all countries in different ways. It's happening simultaneously, so we really can study what's working and what's not. We can learn in real time. And I hope part of what we do is to learn not just across states, and I know that you all have been really engaged in cross-state comparisons, but also that people are able to learn cross-nationally, right? And we can compare not just state to state, but global to global. And Charles, I don't know if I've got the ability to share here, but what I'd like to do is to go ahead and share with you this image, which is what we've been working on recently. So in partnership with UNAIDS and the World Health Organization and UNDP, the O'Neill Institute launched something called the COVID Law Lab, in which we have been gathering laws and policies from across the world. And you can go ahead and we would encourage everybody to go ahead to covidlawlab.org and you can check it out. And what we've been doing is to gather those laws that are related to a couple of key different legal topics. So access to medicines, disease surveillance, HIV, isolation, movement restrictions, et cetera, et cetera. And what we found, right, is that you can then go ahead and we've got, 190 different countries. And this tool allows you to go ahead and look in and see all of the isolation and quarantine measures that we've been able to gather, 298 so far. And then you can go in and you can go to a single law and you can go ahead and you can download it and see the actual legal instrument. And we've been engaged in this for a couple of reasons. One, we think transparency matters a lot. And so the ability to look at these things, to see law, to track it across locations That's something that we think matters a lot. But we also think that there's a lot to be learned across countries. And so one thing I just want to throw out there is that what have we learned so far? So we've done a report, which is online right now with UNAIDS, looking at 16 countries across Latin America and Africa with partners around the world, including the amazing Section 27, the executive director of which you'll hear from in just a second. And we found a few things that I hope we can dive into as we kind of, as we kick off. One is not all lockdown orders are the same, right? And Lindsay's going to tell me that we shouldn't use the word lockdown even, right? So let's talk about that. This idea of restrictions on movements, we can think about what states have done, but even more interesting is, can we think about what countries have done? So, right, some countries have not used restrictions on movement at all, like Ethiopia. Some countries have done most countries in the world, in fact, national lockdown orders, but the US and Brazil have decided state by state is the way to go. So what are we learning about that? Some have done very hard lockdowns. Some have made it entirely voluntary. Some have done curfews like Chile and Jamaica and Kenya instead of doing lockdown orders. The exceptions vary. In Uganda and Botswana, you have to register before you can go out. Whereas in Nigeria and South Africa, exercise has been a key reason you can go out and you can decide it yourself, right? The state of Buenos Aires has said that everybody over the age of 70 has to call a hotline before they were allowed out of their house, on which a hotline person was there, the operator was there and was telling everyone all the dangers and why they shouldn't go out and trying to convince them not to before giving them authorization to do so. A judge overturned that, finding that it was an invasion, right? And so, there's all of these things. In Chile, you can go out for 3 hours of shopping or 24 hours for a funeral. And so these differences of kind of how we're using it have really mattered. So we can look at Uganda, for example, where really strict limitations, as Lindsay was saying, meant that private transportation was banned. 11 people died in childbirth because they couldn't get access to the hospital because they couldn't travel. On the other hand, Ethiopia has done a remarkable job of controlling COVID. They released 40,000 prisoners, and that helped shut down transmission in their prisons in a way that we can learn from a lot here in the US. Supports matter. So in Brazil, non-citizens were given access to health services as a temporary measure because they knew that non-citizens couldn't get access. So these things are different between countries. They're interesting, and there's a ton that we can learn. We can also learn about cross-national pieces, right? We can learn that access to medicines policies are mattering quite a bit. And we can also learn that travel bans aren't working, right? So the US has done a very hard early travel ban, and Canada has not. South Korea has not. And we can judge for ourselves who's responding more effectively to the response to the disease. So with that, let me just close up and just say, look forward to a discussion about kind of where these global and local connections can be made and what we can learn from others. And with that, let me give it over to Umunyana.
Hi, everyone. Thank you so much for having me. This is such an exciting panel. I can't wait. So my name is Umunyana. As John said, I'm from Section 27, which is a human rights organization based in South Africa and working on health and education rights. Section 27 actually refers to the provision of the Constitution that guarantees the right to access healthcare services and to sufficient food and water. So that's the bundle of socioeconomic rights that we have in our Constitution. And as an organization, we work with the law. I'm a lawyer myself, but we have researchers and community mobilizers and communications people, and we use all different types of tools, including litigation, but also protest and public education and research to try and advance the two rights that are the core of our work. We base all of our work on the core values of the Constitution, which came into effect in 1996. So essentially, we are a democratic country of only 25 years, and we're trying to figure out how to transform the country, how to transform the state, and we use the Bill of Rights, which is found in the Constitution, and at the core of the Bill of Rights is the important values of human dignity, equality, and freedom. Having said that, and we have a wonderful constitution that creates equality at different levels, that creates accountability of the state, as well as private actors. But we're still the most unequal country in the world by several indicators. And so our work is really to address inequality in the health and in the education systems. And, this is work that, falls in the tradition of the long line of human rights lawyers who did the work to secure freedom. And so we're able to live in a free country, and we are trying to build a country that's based on equality. Today we buried George Bizos, who is a human rights lawyer and activist. Some of you may know him. He was Mandela's lawyer in the Rivonia trial, which eventually sent him to prison. And George Bizos was an activist lawyer for decades. He worked and believed in justice and accountability. And that's the tradition that we work in. And we continue to build upon the work of people like George Bizos and others, and to try and get transparency and accountability within the state and private actors. And primarily we do that by working with the law, as I said, but also working with grassroots organizations that work within their communities and belong to different structures like the AIDS councils that work with the state at very localized levels to address issues in the HIV program and to monitor the HIV program, which is very important for this country because we have a very high burden of HIV as well as TB. So the work that we do is, for example, on access to medicines. We have worked on changing the intellectual property laws to include a balance between private rights and public health. And we have got cabinet to pass a policy that creates that balance and is leading to serious law reform. And we have our Patents Act, which is a 1970s act and hasn't been substantially changed in many, many years. So that's work that is linked to the COVID work now that we're doing because, as everyone knows, the impending vaccines and treatments, as well as diagnostics, will be required all around the world. And we believe that our legal system has to be prepared for these impending treatments. We also work on the HIV program. There are obviously very gendered dynamics to the HIV epidemic. Young women in particular have the highest burden of HIV, and we have a huge burden in this country of gender-based violence, which during the lockdown actually increased. And so some of the lockdown measures didn't take account of things like, places of safety and things like that. So we do that kind of work. We also litigate. So during the lockdown, we had to litigate against the state to ensure that children who have access to the school nutrition program would continue to have a meal a day. When the schools closed, those children simply had no access at all, and the state didn't have a plan to make that happen. So we got a court order that required the state to provide those meals to children, but also to continuously report back to the report back to the court, so that the court would have oversight of the way in which the court order was being implemented. We also joined with civil society organizations around the country to do things like push for the child support grant, which is a social welfare program, to be extended so that more money was getting into the hands of people who needed them. We also fought for refugees to have access to special grants, what we call social grants. We also, with our partners, got a moratorium on evictions and continue to monitor that. In addition, sexual and reproductive health services around the country were curtailed. And so we got a circular to make sure that abortion and other sexual health services were available to women as they needed them. So that's the kind of work that we do. I look forward to the conversation. I want to thank you for the invitation to join your conference. I must say what I've learned from this COVID moment and other moments of crisis is that solidarity is absolutely key. So I look forward to the cross-cultural conversation to follow. Thank you.
Thank you. Well, thank you, Umunyana. That was terrific. And for all, I wish I could see all the people out there on the Zoom, but I told you this was going to be the A team, and it exactly is. So let's just jump right in. And this, my first question really builds on a lot of what Umunyana said, but really what all three of you said. So we can call them lockdowns, we can call them stay-at-home orders, we can call them, I think probably as Lindsay wisely suggests, we should be thinking of them as restrictions and supports. But there's a lot of diversity, but I'd like to press you to think, to talk about what do you like? What are you seeing that seems like the right way to approach these kinds of restrictions? And I think particularly with the examples Umunyana referenced around consideration for populations that are victims of domestic violence or children that need nutrition, what are the things you're most worried about when you see what's going on around the world? Because I suspect that many of the people who are on this Zoom call are thinking through their own set of balancing issues with state and local government regulation. So who wants to start? Nobody's shy in this group except for this.
All right.
There we go.
Right. Since I'm the one who says never, ever, ever is it okay to keep talking about lockdowns. Everybody's talking about lockdowns, even so. I mean, I'll just say I don't like the term. I think it obscures more than it illuminates because there's such a diversity of responses. And we're coming to a stage where evaluation is really critical. And so if we risk comparing apples to oranges in these evaluations and promoting responses based on those evaluations that may actually vary in critical ways from the responses on which the evaluation is based. And the most important metric by which I would say that these vary is the extent to which supports are available. So that's something I really hope that we can keep discussing. In terms of what I like empathy, and I like creative solutions. I like situations where governments, here in the US at the local level, governments don't have a lot of resources to work with, but I like seeing local governments work with community partners to accommodate safer alternatives to restricted activities. So I like blocking off streets that are no longer needed for traffic to create outdoor spaces that are available to businesses, but also to the general public. I like I love Julia Marcus's harm reduction approach that she's promoting as an infectious disease epidemiologist who focuses on HIV early on. And, she's done this in really publicly accessible communication through outlets like Atlantic Magazine. She was pushing the idea of, this all or nothing thinking that lockdown, reopen promotes is harmful. You lose people when you tell them either stay at home at all times or give up, and instead meeting people where they are, trying to communicate in more nuanced ways about safer alternatives, actions they can take while recognizing the needs that they have, including needs for social interaction.
Anybody else? All right.
Well, I'll take the bait to say, as follows, that I would entirely agree with the kind of idea of a harm reduction approach. And especially when we think about kind of how do you give people information and how do you structure law in ways that incentivize the right activities, right? And so when we do lock down everything and talk about things as if they are similarly dangerous, as if leaving your house is inherently dangerous no matter what you do, then it doesn't give people any tools with which to make decisions that actually can help us drive the pandemic back, right? And so one very clear thing is to really think through kind of what that looks like when it comes to constructing laws, including things like you can go out to exercise, you can go out to parks, you can go out to these places outdoors, and then a very different set of rules when it comes to indoors, a very different set of rules when it comes to public transportation, for example, and thinking through that kind of complexity. The other thing, just to say in terms of don't likes, is that if we we look around the world, there's just a ton of evidence that the most marginalized end up carrying the burden of a lot of the laws, especially when they're broadly restrictive. That means everything from, in several countries, including Colombia, the law said that you could only go out on different days depending on your gender. So women were allowed out one day, men were allowed out another day. Transgender folks ended up getting attacked when they were out on the wrong day, right? So there's these kind of very obvious things that seem perfectly good, right? We want to decongest the streets, let's just divide everybody up, and yet they have these kind of problematic pieces. But then also there's a lot of innovation going on around the world. And so like one of my favorite examples is that in Botswana, there's been a real effort to reach out to give funding and food to sex workers, right? And that work has actually been incredibly important because one of the things we know is that sex workers need access to all sorts of supports. And it's really hard to do that work while you are in a lockdown. And so if you want to incentivize and lift people up, including the most marginalized, then let's actually incentivize, give people a chance to actually take a break. So thinking about all those people who are not going to be able to take a break, even though that might drive a pandemic, even if they're not essential service workers, giving them the supports so that they can step back is really critical. So just to say that.
Umunyana?
I'll just add to what Matt said, which I completely agree with. And I think for me, some of the key things around how the government went about thinking about what those regulations would be. So, for example, there should have been a gendered approach to these regulations. There was no comprehension that women would become vulnerable, even though we have a gender-based violence pandemic in this country. And so there were not enough places of safety, and women were locked in their homes with their abusers. So I think there was a real need to look at what do poor people need? What do people in urban areas need? What do people in rural areas need? Some of the issues in rural areas, for example, was that things are so far apart that nobody could get to the things that they need because they were going outside of their area. So they may have needed to get to food or to healthcare services or to some other kind of service, and they would be stopped by the police. So it's really about being a responsive government and thinking about what are the key things you need to respond to your community. Sex workers is one thing, but also HIV and maternity care. So women were essentially told, don't go anywhere, even if it meant they needed to take their kids for their childhood vaccines or to go for antenatal services. And also there was a lot of reliance on community healthcare workers to be the track and tracers, right? All over the world that's happening. And yet there was no system to pay them. And so charities came and said, okay, we'll give PPE. Can we organize these people in some way? And yet in our public health system, we rely on these people and we pay them very little. So those are the kinds of principles I would say that governments should be looking at.
So we're at a law conference. So let me ask about the courts. I think for an American lawyer, it was hard to hear Umunyana's description of the range of social and economic rights enshrined in the South African Constitution, which of course doesn't characterize our constitutional system, but there's certainly been no lack of litigation in the United States on the response. I guess I'd invite just comments on where are the courts going? Have they been providing an effective guardrail? It sounds like in some cases maybe, or in other cases are they undermining public health responses? So I would invite any comments on the role of the courts and justiciability of some of these issues.
Well, I'll speak a little bit to the litigation in the U.S. and then maybe Matt and Umunyana can draw some connections to litigation elsewhere. In the U.S., as you allude to, John, there are really very few mechanisms to use the courts to hold government accountable for its obligations to provide a public health response. The courts have played more of a role, for the most part, in ensuring that the government's response respects individual rights. Although there have been important court cases that have led to the release of people in custody in the US from immigration detention centers, from jails, from prisons, it's been woefully inadequate. And we know that from the incredible, outbreaks that we've seen in those congregate settings. I think a couple of key themes in the US litigation that I've also seen reflected in countries outside the US. One is the question of suspension of individual rights. In the US, our Constitution does not explicitly address suspension of individual rights, but the courts, starting with a series of abortion rights cases in the US, adopted an interpretation of a decision that we hold near and dear in public health law, Jacobson v. Massachusetts, interpreted that case as holding that ordinary standards of review, including the standards applicable under Roe v. Wade and its progeny, do not apply in a public health crisis, and that instead restrictions on abortion or other rights should be upheld so long as they are not a plain and palpable violation, which unsurprisingly the Fifth Circuit found essentially a pause on all abortion-related care not to violate that standard. It's a controversial question. Other countries handle it in different ways, but notably a lot of countries that explicitly permit suspension of individual rights in an emergency have other checks and balances that we don't have. They have, for example, legislative oversight of the emergency declaration to an extent that it hasn't really happened to the same degree in the US. There's also been battles about who holds the reins on these restrictions, which level of government, which part of the government has the authority. We've seen that with things like litigation by the governor of Georgia against the mayor of Atlanta over a mask mandate, and the extent to which those battles can really impede local self-determination in a city like Georgia, where leaders might take the crisis more seriously and want to impose a mask mandate, even though the state government has taken a different approach. And then we've seen a real struggle beyond that to decide what the role of individual rights should be, particularly around things like religious freedom and restrictions on religious services or religious gatherings, but also more broadly, whether orders for the general public to stay at home that don't quite amount to a police officer sitting outside your door, at least not in most neighborhoods, but in some, whether those orders, how those should be understood in terms of our constitutional framework. Do they violate substantive due process doctrines? Is there a fundamental right to travel within a state or within one's neighborhood? And these orders have touched on an incredible array of open legal questions that we did not have answers to before this pandemic. The courts have begun to provide those answers. It will inform legislative reform efforts, I think, for a decade or more to come.
Excellent. Others? Matt or Umunyana? Comments on the courts?
So maybe I'll go before Matt. So I've spoken about one of the cases that we ran in the middle of the lockdown. But one of the early things that we had to do as human rights lawyers was to kind of just get together and huddle around and figure out how we're going to do human rights lawyering in the lockdown. And so what we did as a group of organizations, and there are 10 or 11 public interest law organizations, we came together and we decided to lobby the Department of Justice to fit us into a category that would allow us to move freely in order to respond to human rights violations. And we got that. So in the kind of next iteration of the regulations, public interest lawyers were included and we were allowed to move around and do that kind of work. We also collectively put up a human rights violation hotline. So people, would call in and say, this is what's happened. I haven't been able to access this or that. I feel my rights have been violated. I've been evicted, even though there's a moratorium on evictions. And so we as a collective began to respond to those cases. And after a while, some of the private law firms also came on board to increase that capacity. So that was really important. But the other thing is that, in South Africa and in other countries, there's been quite a heavy securitized response to a public health emergency, and so some of the regulations didn't make sense and seemed to give police and the military an extraordinary amount of power. In our view, they abused that power. So, for example, there's one case that was being litigated by one of our partner organizations in which a soldier entered the property of an individual and beat him to death. So there's a case in court in relation to that, in relation to the death, but also dealing with a kind of systemic issue around that abuse of power. So the police brutality issue is one that has been a serious problem around the world. And in many cases, you really have to push the public health and human rights response. And that's why comments from the WHO and UNAIDS about a need to involve people who are affected, involve communities, involve civil society are really important. And I think helped a bit of a shift in the response in South Africa, at least, and I hope in other countries, because we found that the military at the very beginning was actually killing more people than the virus was. Thanks.
Thank you. And Matt, I don't know if you want to add anything. I think I might want to just say to the broader audience, I see some people starting to put questions in the chat, so please do, because I think maybe we'll do one more question among all of us and then turn it over to the larger group. I think this is a question Matt will like, so let me, I think we've looked, I think we've looked sort of a little bit back as to what's happened over the last several months this year. I mean, it's hard to believe that we're only talking about a virus that's been around for 9 or 10 months. And what's happening now. Let's look a little bit ahead. You know, there's a lot of conversation at the global and certainly in the United States about a vaccine. We know that law is critical and thinking how we create incentives for, know that there's been a global effort to at least provide some equitable access through the ACT Accelerator. So I guess I would really invite, and maybe ask Matt to start, invite some comments on where do you think the legal flashpoints are going forward? Are there opportunities for law reform in this moment? And are you optimistic about equitable allocation if and when, let's pray, that when we have vaccines? So maybe start with Matt and go from there. I know you've thought about these issues, Matt.
I have a little bit, yeah. I spend a fair amount of my time worried about exactly these issues. I'm not super optimistic, and I'm really worried, right? And I mean, here's I think a couple of thoughts. So again, I work in mostly the global context, and so what we spend a lot of time thinking about is what are the past experiences, and what does that tell us about the future? One very clear past experience is the HIV pandemic, right? The other pandemic that is still going on, where it was literally a decade before people in East and Southern Africa, where the majority of HIV was, in countries were able to get access to the same drugs as people living in the United States. And that was because of the cost of those medicines and the intellectual property barriers that existed to getting people access. And so I'm very worried that we're seeing similar pieces. If we look, for example, at testing, what we're seeing is not just patent barriers, but also kind of wealthy countries purchasing and buying up the entire stock of supplies. So that, you know, there have been countries that have not been able to get a hold of swabs, have not been able to get a hold of testing supplies to do any, right? And that was a huge barrier because of global supply chains. And as we think about a vaccine, I think there's a couple of things to say. One, you know, there really are alternatives to the way in which we're currently doing things, right? And so I worry when I see, for example, a Moderna or another vaccine coming out, and we discover that it's 100% financed by the US taxpayer, right? And so that is great news, because that means we're putting lots of funding into and behind a really critical need. But when that's happening, the US federal government has a whole bunch of options when it comes to legal recourse to make sure that that is available, right? There's marching orders, there's a variety of things, not to get too complicated. Or we can say what we'll just do is award a patent and then sort it out later. And instead of putting strings on some of these pieces beforehand, we're not doing that. And what that's going to mean is that there's going to be monopolies over the vaccines. And that is deeply, deeply worrying because there's kind of two core questions when it comes to who's going to get access to a vaccine. One, who owns it, right? And so when I see news that what's happening is we have a spy versus spy hacker attacks between the major powers of the world, what that says to me is we're incentivizing the wrong thing. Why in God's name would you need to hack in to find out information that should be public about how best to create a vaccine for people, right? And that says that our patent system, to me at least, is really driving the wrong answer. But then the other is to say, with all of the money that the US is putting in, the US should also really be thinking about what does that mean on a global scale. And so when the US is buying up as much as it possibly can of the supplies of a future vaccine, that means that there will not be doses available for the rest of the world. And so as we think about what low and middle income countries are going to be able to do, I would really urge folks who are thinking from a public health law perspective to think about ethical allocation around the world and think about what does it mean to both ensure that the information is open, including support to production in countries outside the United States, right? Once it's discovered, if the companies then support the kind of knowledge transfer, then doses can be produced around the world. But second, that the US not do a thing which is currently doing, which is saying every American should get access to the vaccine before the first fill in the blank country, because we're trying to buy up as much of the vaccine as we can. And there's a really interesting article just out by Bill and Melinda Gates Foundation that actually shows that that will serve us poorly. That far more effective would be if the US vaccinates 20% of its population and lets the rest of the world also vaccinate 20% of the population, because that's actually going to drive down rates of the virus around the world. And that's what we need to stop the virus here in the United States. And so it's actually not in our interest to buy up as much as possible. And so for public health folks that are thinking about this and thinking about it at a local level and at a national level, I would really urge a kind of much more global perspective when it comes to those things.
Thank you, Matt. Yana or Lindsay, I suspect you all thought about this as well. There we go.
Maybe I'll talk a bit more about the intellectual property work that we've been doing. I mentioned that that's one of the issues that we work on in order to increase access to medicines. And we've been successful in developing this policy. But what is actually needed is for legislation to be put through Parliament and passed. And some of a lot of what we've asked for and what is currently in the policy is really uncontroversial. It's things like we should substantively examine patent applications. We shouldn't just award a patent because it's been applied for, which is currently the system that we have. And also trying to limit multiple patenting or what we call evergreening, to ensure that we're not increasing the monopoly of pharmaceutical companies beyond the initial 20-year monopoly that is granted by a patent. So that's the kind of policy work that we're doing and the law reform that has to happen. But the other thing is, I think it's important to think about where we are now as well in terms of the clinical trials, and to examine the laws around clinical trials in countries, and I guess in states, and to understand what is the quid pro quo in terms of what that locality gets as a result of participating in clinical trials. And South Africa actually has a really good history and excellent scientists that work on clinical trials on various diseases. And so we had the ability to kick off and participate in some of these global trials. But it also is very complex. So we actually don't know what the terms and conditions are and what will happen should a vaccine actually emerge from some of the trials that South Africans have participated in, and what that means for the rest of the African continent and other low and middle income countries. So that's another area of law that tends to be quite complex, but is very important for future access.
I'll just add in terms of both participation in research trials and access to vaccination and acceptance and trust of vaccination. I think some of the same patterns that we're seeing in terms of the impact of social subordination, past and present, are likely to continue to play out in the vaccination space. And it's ironic that while we're talking about ensuring just and equitable distribution globally of these vaccines. We're also talking about potentially imposing a highly command and control police focused response here within the US to potentially mandate vaccination particularly for frontline workers, many of whom are hesitant, many of whom distrust the idea of what feels like government experimentation with a new vaccine, what feels like a response that's not based on the safety or health of the worker themselves, but rather the protection of others. And I think it really goes back to a critical piece of the entire response, which is trust. Maintaining the public's trust is an absolutely critical, the most precious resource in a public health crisis. And many of our responses have threatened to erode that trust. And I think it's something that we need to, that we'll experience negative impacts from as we shift to a vaccination campaign at some point in the coming months or years. And something that we need to keep in mind as we think about the role of law in that vaccination campaign.
We encourage people to send in questions, but I want to follow up. We haven't talked much about the regulation of information, and that is obviously a role for law. It's potentially fraught. On the one hand, law can promote science and scientific understanding, but obviously people are worried about misinformation. We're worried about hesitancy. How do you all see or think about the role of government in regulating information flow during this next stage of the crisis? Oh man, I never thought I'd come up with a question that nobody'd have an answer to. I guess I would just ask you, given what we've seen so far, it strikes me that, we've seen government overreach. You've raised all kinds of issues about how governments have responded quite differently, but have been problematic ways. I don't know why we wouldn't, why wouldn't we expect some of those same issues to arise if government needs to regulate information more for their citizens, or chooses to, whether they need to or not?
So look, I think that this is, so I'll reveal myself now as actually a political scientist, right? Which is, government, has a number of tools at its disposal. And we have seen over and over and over again that government regulation of messaging is really messy and rarely done particularly well. But that government has the ability to spend and message when it decides to in ways that nobody else can, right? And so one kind of thing that has just very clearly not happened in the United States and has not happened in Brazil, has not happened in the UK, but has happened in South Korea, has happened in Ethiopia, has happened in a variety of places, is a very clear whole of government response to say we have a set of messages about how we're gonna kind of communicate. We're clear on what that looks like. We're coordinated across agencies. We're coordinated across federal and national and state level. And we're gonna actually put money behind that, right? We're gonna actually put people out into the world, and we're gonna pay attention to what kinds of messengers actually work for people. And so if people are listening to their pastors, if people are listening to their celebrities, if people are listening to all sorts of folks, then governments that have been effective have harnessed all of those, right? Some of the most effective messengers have actually been K-pop stars in South Korea, who have been on point, who now know more about the transmission of coronavirus and what can happen than anybody else I know. And they have been the most effective messengers, and they've had government behind them rather than government in front of them. And that's, I think, the core thing that we're missing here, which is how do we get information? How does government use all of its tools? Some of the most important of which is legitimacy, some of which is also kind of the ability to spend finance to actually put it behind those. So anyway, that's my rant. Yeah.
Anyone else want to jump in?
I'll just say in the US, the sort of elephant in the room here is that it's been the opposite of that. We've had clear messaging and modeling from leaders, not only at the federal level, but in some states as well, that has been contrary to the public health guidance coming from the same part of the government, right? So messages from the president that undermine the CDC's guidance, interference with CDC's guidance, conflicting messages between state and local and federal responses. And so in that environment, it's confusing. It's also easy for people to just throw their hands up and say, oh, it's kind of like, is chocolate and coffee good for you or bad for you? Scientists don't really know. Scientists don't know anything, right? Let's just go about our lives. And I think that's done a great deal of harm in the US response, to have that messaging be so at cross purposes. You know, and an early example, of course, is the messaging around masks in the US, where there was a switch, and that switch may have been completely understandable based on evolving understanding about asymptomatic transmission, but it did a great deal of harm to public trust and cooperation at a very early stage, and it's been hard to recover from that.
And I would be remiss not to just quickly note that that two things are true. One, the United States was at the top of the Global Health Security Index. In theory, we're supposed to have the most capacity in the world. And so we see the role of messaging and leadership in government just out the window. And second, that this attack on the World Health Organization that's come from the United States has been deeply damaging. We're in the middle of undermining the only global coordinating mechanism we've got when it comes to messaging, when it comes to kind of getting folks together. And so if there's not a global messaging effort, and if instead the United States is actively kind of undermining global public health, that's actually super damaging to halting the pandemic around the world, which is not helpful for halting the pandemic here in the US.
Umunyana, I think we're down to about 5 minutes, and we did have one question come in, and I think it may be a good closing question, if you will, for everybody. One of the people in the audience raised the question of mental health, which we haven't discussed, and the impact of the COVID-19 pandemic on mental health and what government should do to respond. I would just broaden that to the other health issues that the public health agencies and health agencies around the world are dealing with, and so we have to think about, how is this response? We've talked about all the challenges, the legal issues, and others in the response to the pandemic. But what does it mean for everything else that we know are necessary for people's health? And I might take the lead of maybe asking Umunyana to start us off, because I know, obviously your work covers such a wide terrain, and you've all been working in such a broad set of areas around people's health. Maybe you could start us off, and then I'll just ask everybody to comment on sort of effect on systems more broadly, if that's okay. Umunyana, would you be able to start us off?
Sure, thanks for that question. I think it's so critical, not only for responding to COVID, but also the recovery. We're talking about economic recovery, getting people back to work. How do we get everyone working and get the economy working again? And that's a conversation that's happening everywhere. But a health system that has been revealed to be so weak, which is true of many countries, including South Africa, it just means that we have to build up our health systems. So we have to be ready for the next, we have to be ready, for example, to roll out vaccines and treatments. What are we going to do? Do we have a cold chain system in place that is going to ensure that we can move vaccines from city to city and into rural areas? How do we do that? But also, how do we recover the kind of drop-off in HIV and TB diagnoses? Tuberculosis is the biggest killer in South Africa. So how do we deal with the fact that we haven't been diagnosing people because they haven't been coming to their local clinics, which means we're going to have a bump at some point and have to deal with that. And will the system be ready for that? Mental health is also very important. We treat mental health as though it's a nice to have in many countries, and it just isn't true. And we're always trying to find ways to improve the legal system, whether it's through the health insurance, which limits benefits quite substantially for mental health services, to kind of exceptions around, can you do telemedicine for mental health services? yes, we've been able to do that, that's been successful, and perhaps we can then extend that so that more people are able to access mental health care services around the country. So I think there must be a real sense of how do we recover and build upon our health systems. We talk all the time about universal health coverage, and we have to figure out what that means in a health system that has been shown to be so broken. What do we say about preventive health care? And so I think for us, a key priority, the work that we have to do beyond kind of the end of 2020, 2021 and so on, is to really think about how to build our health systems to withstand the next pandemic, which we know is coming.
Matt and then Lindsay.
You know, I think one of the things, and I'll just go off one of the questions that was also in the chat box, just to take advantage, that one of the questions in there was about the kind of what examples have we seen of transnational collaboration, of international cooperation, and building off of what you were saying, Umunyana. The African Union has actually shown us the way in some of this, right? Which is, you know, we kind of in the United States often pride ourselves, and again, we were #1 on the Global Health Security Index, and yet the pandemic has overwhelmed the United States in ways that it has not elsewhere. Where we actually need, I think, in the United States is a bunch of humility, right? And to look and to say, what can we learn from? Many of the most powerful, smart, experienced epidemiologists and responders to pandemics are in East and Southern Africa, are in West Africa responding to the Ebola outbreak, have responded to the AIDS response, the AIDS pandemic. And so what can we learn from that? And one of the things that we've learned over and over again, and what the African Union has to help do, is that A, cross-national collaboration matters, right? That we think about kind of between countries as a key place, but that B, we need to think about mobilizing the infrastructure from one thing to do on the other, right? And so what we've done is we've closed down aid service organizations in the United States sometimes because they're not serving COVID responders. But instead, right, why don't we get the people out that are peer network workers, right, out to actually be doing contact tracing and thinking about mobilizing those things, right? Thinking about how do we use all those mechanisms, because people living with HIV are also going to experience COVID, because people in the middle of breast cancer are also going to be experiencing COVID. And so, like, how do we think about mobilizing those responses and those capacities? And then how do we also learn from our high-tech, corporate response when it comes to public health is not serving us particularly well? Some of the low-tech responses are being way better.
Matt, that's just the kind of horizontal learning I was hoping we'd focus on today. So thank you. And Lindsay, the final word, and I'm sorry that we have to be brief, but please.
I'm just honored to have the chance to end this closing plenary by thanking those who are in the audience, who are working in state and local health departments, in the federal government, in academic centers, in think tanks, in public interest law firms, and so many other settings, to respond to this crisis, but already to also be thinking about how to build a new normal with our health system, with our global cooperation mechanisms, and hopefully one that centers public health and health equity and justice. So thank you all for the work that you're doing. Keep it up. And for the years ahead, we'll continue to support each other and build this community around events like this one. So thank you to the Network for Public Health Law as well for hosting this important event.
And I'll add the final thanks, which is to the three of you for taking your time and your wisdom and experience. It was a really, I thought, provocative and really helpful conversation. So I hope it helped us learn both vertically and horizontally how to think about experiences around the world. So with that, I just want to turn this back to the folks at the network and thank everybody for today.
Thank you.
Charles?
Thank you all. Yeah, I think you about covered it. I know we're a little over time here, so I just want to give a final thanks to everyone who attended today's summit. You know, this is the last day of our summit, and it's just been an overwhelmingly positive experience for all of us here. So thank you all, and have a great rest of your day.
Thank you.